This is ESC TV. I'm Juan Carlos Zerpa, and welcome to EHRA Snacks, now on atrial fibrillation. I'm joined by two of the presenters of the late-break clinical trials of atrial fibrillation, Dr. Sandrine Venier from Grenoble, France. Welcome.
Thank you very much.
And Dr. Birnie from Ottawa, Canada. Welcome.
Thank you. Thank you for having me.
It's a pleasure to have you both here to talk about the science the users presented about atrial fibrillation ablation. Dr. Venier, can you tell me about the highlights of the FACIL AF trial? What did you compare? This is a randomized clinical trial, right?
Yes, this is a multi-center with seven French centers with high volume, randomized and controlled trial, which compare cryoballoon ablation and pulse field ablation, designed in non-inferiority trial.
We have several non-inferiority trials before, like Advent and the single-shot champion.
Yes.
What is the difference on your trial?
In the Advent trial, the comparator combined radiofrequency and cryoballoon, leaving uncertainty regarding direct comparison with cryoablation. And in the single-shot champion trial, the monitoring is a continuous monitoring with internal loop recorder. So this is a little bit different, and it's 2 centers with 200 patients. And FACIL AF will extend this evidence in a real multi-center trial with standard routine monitoring.
And this helps you make a difference when the more you look for atrial fibrillation, the more you will find. How this was done on your study, on the FACIL study?
Yeah. The event rate at 12 months in our primary endpoint results are very low because we have 18.6% of recurrence for the cryoballoon group and 14% in the PFA group. So we have non-inferiority for PFA, and this is really good results. In the single-shot study, the same non-inferiority is showed for PFA, but the event rates are very high because of continuous monitoring. So the continuous monitoring is more accurate for a clinical study, but in the clinical routine practice, we treat symptomatic atrial fibrillation, and then this is what we use in clinical practice. So it's difficult to know what we have to do really, because we know continuous is more accurate. But in routine clinical practice, we continue to use Alta ECG and connected device.
Exactly. And that led us to what do we do with this data? And Dr. David just presented the sub-study of the Ocean trial. And with this information that we're trying to find atrial fibrillation burden and what to do with this, how do we manage the anticoagulation in these patients?
Yeah, no, I think Ocean is going to change clinical practice. Ocean wasn't presented today, but Ocean, as we know, randomized patients to continuing oral anticoagulation against stopping, and we found no difference in stroke events. My presentation today was a sub-study where we looked at just patients. We compared subgroups of patients with atrial arrhythmia recurrences and those without recurrences, and we didn't find any difference in any stroke events, including we had cerebral MRIs on everybody, and there was no difference in even small strokes between the two populations.
So is it possible to have these small strokes independently of the atrial fibrillation burden, and you don't see any significant difference between maintaining the anticoagulation and going to aspirin?
Yeah, it's not clear. You know, I don't think we can say whether these are non-AF strokes, because or they are AF strokes. They're probably not. They're probably lacunar infarcts, which are more related to hypertension. The key point, though, and the key clinical message is that these patients can never be told they're cured from ablation or from atrial fibrillation. And they need to have some sort of follow-up, and not necessarily by cardiology, but just some sort of check in, every few months as to what their rhythm is doing. And if they do go back into atrial fibrillation, they need to restart.
Exactly. And that led us to a difficult question that I did to Dr. Batista when we were presenting. We are so good doing atrial fibrillation ablation. We compare PFA and cryoablation, but the results are almost the same. It's difficult to get better, and maybe it's for that, because we cannot cure atrial fibrillation. We have control of these, and how were these results in your FACIL AF trial? Because we say we have the same efficacy, and how is the safety profile comparing both?
The safety profile, we reported the acute complication and the 12 months complication, and the difference is not significant between PFA and cryoballoon ablation, but we have a trend in favor of PFA, mainly due to the phrenic nerve palsy in the cryoballoon ablation group, but not significantly different.
And how will this impact clinical practice here in Europe, and also thinking back to America? How do you think the OCEAN trial is going to make this a difference in our clinical practice?
We're not America, we're Canada, very different.
Yeah.
We have to make that point now.
Yeah.
You know, I think PFA is here to stay. You know, I think that your study just gives us more information. You know, I think all of the studies are saying the same thing, that, you know, it's at least as good, probably better, and probably safer, and definitely safer.
Definitely safer.
And the procedure time is shorter in PFA significantly. So the shorter is the procedure, and the shorter is the risk of stroke also. So it's important.
Yeah. As we get better and better doing pulmonary vein isolation with this new technology, we're going to improve. We have more stable results and more control of the AS burden, and that's going to make us face maybe more safety in the decision of stopping anticoagulation. What do you think about a final message about these results of the FACIL study on the sub-study of the OCEAN trial?
Well, for me, the final message is very reassuring for patients. You most, you know, up to about Chad's VAS 3, you have a successful ablation. You can almost definitely stop your oral anticoagulation. The key clinical message is you're not cured, and you have to have some follow-up and restart your anticoagulation if you go back into atrial arrhythmia.
And I think that probably PFA will replace the cryoballoon ablation in the future for the single shot technology.
Yeah, I think that too, and hope that we're going to have this information soon, just to make these changes in our clinical practice. Congratulations, both of you, for the work, excellent presentations at late breakers in EHRA, and thank you for being here with us in EHRA TV.
Thank you.
And thank you for watching EHRA TV. Don't forget to follow in the social media, the EHRA TV and the ESC TV. Thank you.